Hi, my name is Jerry Hesch. I'm a physical therapist and a manual therapist, which the definition of a manual therapist means that you have a deep understanding of how joints work, and you treat joints to restore motion losses, and you treat joints to stabilize them, and also treat for reduction of pain, and we also treat soft tissues, and we teach our clients, we educate them on recovery from injury and exercise, etc. What I want to talk about today is the calcaneus, which is the heel bone, and we have another video up, and we have some extensive writing on it. And if you would go to the website heschmanualtherapy.com and then find foot and ankle, and then if you go down to type 2 cuboid syndrome, this relates to that. This is one of the best models in the world. It is a SAMSO German model, and it is absolutely precise. Using this model with the ligaments, I'd like to demonstrate to you, and it's going to be difficult for you to see, but right here is the back. Okay, this is the back of the ankle joint. Okay, so this would be the lower leg bone, and so the ankle moves like this. Okay, when we walk, our foot goes up and down. That's ankle motion. Now, there's a little bit of side bending in that joint also. Okay, there's a little bit of this movement that occurs in the ankle. Barisan Valgus is what it's called. There is also a little bit of transverse plane rotation where the foot, and I am clasping the talus, which is a big bone that sits between calcaneus and the tibia and fibula. Can you see the foot goes to the left and to the right? That's the concept. Okay, now if I stabilize that joint, then I'm going to get into what's called the subtalar joint. And that joint, I have extensive drawings and pictures on the website. That joint, it connects the talar bone, that little chunk of bone that's in the ankle. It connects it with the calcaneus. Okay, the heel is a pretty broad structure. I'm grasping it here. You can see it's a pretty long guy, pretty wide. It is, of course, the biggest bone in the foot and ankle. Where am I going with this? I drilled this today so that we could insert AXES, so that I could dramatically show you the significant amount of rotation that is possible in the foot and in the subtalar joint. And to show you that a little bit occurs when you move both the subtalar joint and the ankle joint, also called talocrural. That's the point I want to make. There is so much emphasis on the fact that the heel goes into this direction, which can be called inversion and can also be called varus. Okay? And when the lower heel goes outward, that is called eversion or valgus. And different professions use it in different contexts. Some will use one term when the foot is off the ground, and some will use the other term when the foot is on the ground. I choose not to make that distinction. Okay, so here we go. With this fabulous and very expensive model, here is calcaneal valgus, because the lower part is going outward. Okay, and then here is calcaneal varus. And this model is difficult for me to move. It is so tight, so I need to distract it a little bit. Okay, and you can see the motion. Okay, this one is much less constrained. Okay, and this model is not designed for this kind of a demonstration, but now when I really distract it, I can get a lot of left and right movement, which is called abduction, and when I distract it, there's a little bit of valgus, and a little bit of varus as well. Okay? I would, certainly in this model, a lot less varus. And now I'm freeing up the talus. So here's your varus. Okay? And here's your valgus. Okay? And again, we have all the ligaments intact here. I am not dislocating anything. So you can see that there is, a considerable amount of motion, and now that rotation is coming in. Okay, easier to demonstrate without a lot of ligaments over the structure. I appreciate this is not a human foot. This is not a cadaver, or it's not a human being, but we can't take someone's foot out and demonstrate this. The purpose is demonstration. This is a perfect model to do so. Now, for example, if I were to dislocate the calcaneus, if I could just shear it off and it's connected with bungee cords, then that would not be a valid test, valid demonstration. But if I look at the articular surface, of the joint, and I move it in such a way that it does not slip off of that articular surface, then I think it's a fair demonstration. So here is the back of the heel, and there is some movement in the transverse plane in the ankle. If I constrain the talus, there is considerable rotation. And if you look at the shape of the joint, again, I refer you to that website, you can see that it is very slopey and that it really looks like it is designed for rotation much more than it is designed to swing into varus and valgus. Now here, if I distract it, here's varus and valgus. So I'm going into varus and returning back to neutral or going into valgus. And I'm sensitive to watch the articular surfaces. I've got them marked here laterally. And so that when I take this calcaneus and I move it into varus, and then I move it into valgus, I'm making sure that these surfaces do not come apart shear. That's my point. In treatment, the rotation is extremely important, and sometimes, and many times, you can restore calcaneal valgus, which restores functional movement in that joint, which can be lost with ankle injury, repetitive trauma, etc. And we can measure that motion with goniometers and such, but I'm not going to do that. I hope that I've succeeded. The one take-home message I wanted to accomplish here was the fact that in the ankle and subtalar joint there is considerable transverse plane rotation. Therefore, we need to evaluate and treat it when it's lacking. And even if you constrain the talus and then move the ankle, there's considerable rotation, much more so than the lateral or eversion or valgus, and the medial towards midline varus, much less. And that is my point. Thank you very much.